a clinician and public health practitioner, so we're kind of looking at the other spectrum of a lot of what's been discussed already this morning. But I hope you'll see that the importance of good thinking and strategies around improving uptake of vaccines, both for children and for pregnant women. And I've chosen pregnant women because really this is a fairly, well, not exactly new area, but certainly an area we're seeing additional vaccines being included for pregnant women, but also under development. So I'm just going to talk a little about why we're vaccinating pregnant women. Some of the recent recommendations that have been made, particularly in high-resource countries, but also thinking about developing countries as well. The effectiveness, so we've done quite a bit of work, a systematic review around effectiveness and safety of maternal immunisation, and then looking at uptake and what strategies are likely to be effective in improving uptake in pregnant women. Because I think for pregnant women, they are a different group to children, and so the strategies may be different. So why do we immunise pregnant women? Well, they're at increased risk of serious disease, complications and death, and this particularly awareness around this during the H1N1 pandemic, where it was noted that a lot of the beds taken up in ICU were actually pregnant women, and with some serious outcomes, and I'll show you some of the data from that. So it's not only that the pregnant woman may have complications and potentially die from those complications from influenza, but there's also adverse obstetric, fetal and neonatal outcomes from influenza infection. And we know that particularly neonates and young infants up to about 4 months of age have an increased risk of severe disease and again death from serious infections, particularly pertussis and other severe bacterial infections. And that's because they haven't yet developed their own active immune responses, because they haven't undergone primary immunisations until, for most countries, starting about 2 months of age. So for infants, maternal immunisation improves the transfer of vaccine-specific antibodies from the mother, and in a dual effect, reduces transmission as well. So although you're getting a nice rise in antibodies in the fetus and neonate, you also have the added bonus of reducing transmission, preventing the mother from becoming infected as well. And the World Health Organisation has identified pregnant women as the highest priority group for funded immunisation, influenza vaccination programs globally. So I think that just raises the level of importance of this area. So we have maternal immunisation really providing this dual protection for both mothers and infants against serious infectious diseases. So just to show you some of the data on the burden of disease for pregnant women. So this comes from the Australian New Zealand ICU physicians group, who published a paper showing the burden of disease particularly during the H1N1 influenza pandemic. And this was just data collected over a 3-month period from June to August in 2009. So 64 pregnant or postpartum women were admitted to intensive care during that 3 months. 39% resulted in a preterm delivery. 7 women died. There were 4 stillbirths and 3 infant deaths really related to premature delivery. So, you know, there is a significant burden for pregnant women. And they identified from that study that that pregnant women had an increased risk of 7.4 times that of the general public being at risk of ICU admission. And if it was in the latter half of pregnancy, the relative risk was 13.2. So for infants, you may not be aware that infants, particularly young infants, have the highest burden of disease, particularly for notifications and hospitalisations. So you'll see here in the graph, if those you can see, under 5s have the highest notification rate, and then if you look at the under 1s, they have the highest notification of that rate of that group. So they have significant burden. They transmit infection as well, and they're really sort of super spreaders of influenza infection. And unfortunately, there's no influenza vaccine licensed for use in infants under 6 months of age. So the only way of really providing protection in that early neonatal period is through maternal immunisation. So for pertussis is the other vaccine that's more recently been recommended for pregnant women. here in the UK and the States and Australia. We really have very little data about whether pregnant women get infected by pertussis very often. We don't know what the burden of disease is. There's no published studies on that. But for infants, we know that for young infants, as I mentioned before, if they're under 2 months of age and they get pertussis, they have an increased risk of death, complications, severe disease, hospitalisation, and particularly if they're premature as well, they have an increased risk of severe pertussis. So even if they're hospitalised, if they're premature, they're more likely to end up in intensive care. The reason being that they haven't had a chance, as I said, to develop their own immune response to pertussis immunisations, which start at 8 weeks of age for most countries, 6 weeks in Australia. So there's been the recent recommendations, particularly in high-resource countries, for influenza vaccination, which is recommended at any stage of pregnancy, first, second or third trimester. In Australia, we have a Commonwealth-funded program, and it's part of that. For pertussis vaccination, which has only recently been introduced, it's recommended in the third trimester of pregnancy, not because of safety concerns around the other trimesters, but because it's seen to be the optimal time to get that transfer of pertussis antibodies to the infant. In Australia, it's a state and territory funded program, so all the states have come on board because, and this is very unusual in Australia, it's because it's been seen as such a high priority, and the Commonwealth are not funding it. Each of the states has taken this on to fund pertussis for pregnant women. So these recommendations around influenza immunisation were really based on this risk to mum of the mother of the complications from influenza, particularly in the later stages of pregnancy, to provide that protection for infants in the first 6 months as they don't have a vaccine available to them under 6 months of age. Good evidence that the flu immunisation in pregnancy is safe and effective, and really a recommendation that all pregnant women receive the flu vaccine as early on in pregnancy, just to get that benefit and make sure that they have protection on board in the later stages of pregnancy where their risk goes up again. So this comes out of a systematic review that we conducted in my group, looking at the effectiveness. And really, I mean, overall, I've just provided some of the results here, but really flu vaccination in pregnant women is about the same as the general population. It depends a bit on strain, whether it's a good match to the vaccine's a good match to the circulating strains during that influenza period, but it's around about 51 to 61%, depending a little bit on the methodology that's used in the vaccine effectiveness studies. And this is one, I've just really given you an example here. This is quite a robust study where they've done a case control approach, but they've used confirmed influenza with this adjusted vaccine effectiveness of 51%. And then for infants, this has become, I guess, an interesting area of research for us, and we're part of a large national study in Australia to look at flu vaccine effectiveness in infants to 6 months of age, called FluMum, where we're enrolling 10,000 maternal infant pairs to look at the effectiveness of flu vaccine in preventing flu, laboratory confirmed flu in infants to 6 months of age. And this data really just comes from systematic review, showing, depending on the study design, again, vaccine effectiveness range from 48 to 91.5% in preventing influenza, maternal vaccination preventing influenza in infants to 6 months of age. So safety, very important again, and these are results from our systematic review we did of fetal safety of influenza vaccine delivered during pregnancy. And out of our systematic review, we were able to conclude that there are no safety concerns identified in the 24 studies that have been published looking at fetal safety. So you can see there for congenital malformations, which again is a tricky one because most women actually get vaccinated in the second and third trimester, not the first trimester. So if you're vaccinated in the second and third, it's very unlikely that you're actually going to have a causal congenital abnormality from the vaccine. But from the studies where they did vaccinate in first trimester, there was no increased risk of congenital malformations, no increased risk of spontaneous abortion or fetal death. And you can see here from just looking at the odds ratios here, just around the fetal death data, the only one that this all looks very good, that you're less likely to have a fetal death in the vaccinated versus the unvaccinated group. And you just see this one here that's odds ratio of 2.95, which you might feel is concerning. Very wide confidence intervals here, but it's actually a study done in 1981, or published in 1981, of a swine flu vaccine that was developed in the 70s, and is quite different to the vaccines we have now, so not of concern. So from our flu mum study that we've been, the national study, we've been looking at uptake of maternal influenza vaccine, and just to compare it to other countries around the world, the UK have reported about 40% uptake of flu vaccine in pregnant women. The States about the same. In Australia it's lower than that, only 33% uptake, and you can see some variability around the States. We're collecting this data, of course, in every state. I'm from Adelaide here. You don't know where Adelaide is. And we're even lower again at 27%. So quite concerning when there's a burden of disease, there's a safe and effective vaccine, but uptake remains quite low and inadequate. So we're interested in looking at ways we can improve that. So if we look at the pertussis, maternal pertussis immunisation recommendations, as I mentioned, it's recommended in the third trimester from 28 weeks, and recommended in Australia for every pregnancy. So these recommendations have been based on the fact that the DTPA vaccine, pertussis vaccine, pertussis diphtheria tetanus, has been shown to be effective in preventing pertussis disease in newborn infants, and I'll show you some data around that. And that immunisation of mothers at least 7 days before delivery. If it's less than 7 days, there's less likely that there's good transfer of antibodies, so less likely it's protective. But if you give it at least 7 days before delivery, it's 91% effective, which is fabulous, really, in preventing disease in infants under 3 months of age. One of the issues though we find is that you do get this quite rapid decline or decay in pertussis IgG levels after delivery and when antibody levels are taken over a 2-year interval between pregnancies. And this has really resulted in our recommendation in Australia about giving the pertussis vaccine with every pregnancy. And just the other thing to note is that although there hasn't been a study showing a direct comparison of vaccination during pregnancy compared to giving it postpartum, so what's considered the cocooning strategy, so given after delivery, that it does appear that immunisation in pregnancy is more effective than the cocooning strategy. The pertussis antibody levels tend to peak 2 weeks after immunisation with active transport of antibody to the fetus from 30 weeks, and that's why we try to suggest that it's given around that 28-week gestation period, particularly between 28 and 32 weeks. And you've got to think too, if we know that premature infants are at more risk of severe pertussis disease, then you want to be making sure you get the vaccine in before a premature delivery of a prem infant. So there's a bit more flexibility in the States around this. That they've sort of said, it can be a little bit earlier than 28 weeks, just to try and avoid that situation. And it may be with if you have a pregnant woman who has had a previous preterm birth, that you might especially try to have her immunised at 28 weeks or a little bit before. But as I said, it's not really a safety concern, and the vaccine can be given at any time during the third trimester up to delivery. And if you do miss out on giving the vaccine during pregnancy, it certainly can be given afterwards to reduce chance of transmission. So the only concern we have about this strategy about maternal immunisation for pertussis is that some recent data, this was just presented in May in Expo in Germany this year, is that in infants whose mothers received pertussis vaccine during pregnancy, their antibody responses to the pertussis antigens here were lower than historical controls where women were not vaccinated during pregnancy. So it looks like vaccinating mum during pregnancy may actually give a blunting effect for the infant's immunisation responses. But the clinical significance of that is really unknown, unlikely to really be of concern, and particularly where booster doses are given at 18 months of age. They've shown that there's really very little difference at that stage in both the vaccinated and unvaccinated groups. So the whole idea is that you're really trying to prevent the very young infants from getting severe disease or dying from pertussis. You may see some blunting later on, but it's unlikely to have clinical significance, and if you have a booster program, then you're very unlikely to see any effect from that. So the vaccine effectiveness data on pertussis in pregnant women comes from the UK. So Public Health England have done some fabulous studies and published them in recent years after implementing the program here. So the UK, I think, was the first country to implement a pertussis program for pregnant women, and they've shown the vaccine effectiveness in infants under 3 months of age, 91%, if it's given over 7 days prior to delivery. If it's given in that 7 day to up to delivery time point, the vaccine effectiveness really drops down to 38%, and those wide confidence intervals. So ideally you give it over 7 days prior to delivery. And some of the data from the published studies that come from the UK just show there were 14 deaths in infants with confirmed pertussis in 2012 prior to implementing the program, and then only 3 deaths in 2013, and those 3 deaths were in infants, all in unimmunised mothers. So I think it's quite impressive how well that program has gone here in the UK. Safety, of course, again, very important for pertussis vaccination in pregnant women as well. So here again, in the UK, 20,000 vaccinated pregnant women. They looked at the safety data. Now they used a DTPA IPV vaccine here for their program, and they found no increased risk in stillbirth, preterm delivery, or any other of the, I guess, more rare complications, obstetric complications that you might see. So very reassuring. And here in the UK, they've managed to get very high uptake. We were all very impressed with this. Don't worry about these different colours. They're just at different time points during the pregnancy when the vaccine was given. But you can see here, we're getting up to sort of 75%. So we all sort of sat back and thought that was absolutely fantastic, a fantastic achievement. And if you look at our pertussis vaccine uptake, remembering that our program only really started early this year, that prior to our program, it was only about 3% uptake in 2014 during pregnancy. Then we introduced a statewide funded program, started in Queensland first, so 29, they've got the highest uptake there, but then all the states came on board. We're sitting at 21%, 18%, so nowhere near as successful here as the UK. So we were trying to determine strategies to improve uptake. So some of the data that we used we looked at whether there was a concern amongst pregnant women about receiving vaccine in pregnancy, and this is particularly around flu vaccine. 39% were aware it could stop you getting the flu in pregnancy, and 71% suggested less severe flu, but 46% thought the flu vaccine could make you sick, and 7% thought the flu vaccine was worse than getting the flu. And 50% could harm the unborn baby. So some mixed messages and understanding around flu vaccine and concern from pregnant women. And then more qualitative data showing that many pregnant women were not aware of the immunisation recommendations, and that if their healthcare provider endorsed it, was a very, really important factor in encouraging them to be immunised. Although the role of the healthcare worker was identified as vitally important, many of them had not been advised of recommended vaccines. So we then went and had a chat to the healthcare providers as well, and they said, well, it's not part of standard care, it's not really on our radar, we've got so many other things we're doing in the antenatal clinic. If it could just be incorporated into standard care, it's likely to be far more successful. And I won't go into all of that, but so really we felt the strategies to improve uptake were to enhance the confidence in both the healthcare workers and pregnant women around those messages about how safe and effective the vaccines are, encouraging healthcare worker endorsement. Pregnant women basically said, look, if our healthcare worker, our obstetrician, our family physician tells us to have the vaccine, we will have it. Improving accessibility of vaccines, so implementing vaccines in antenatal clinics, making sure the vaccines are available for pregnant women when they turn up, and then incorporating vaccines into standard maternal care. So we've done that in the hospital where I'm from, the Women's and Children's Hospital. It's a maternal and paediatric hospital. Midwives have been trained in immunisation delivery right in the clinic. It's been included in perinatal guidelines and part of standard care. And as you can see here, really our rates have skyrocketed just by implementing those very basic things, so that in June, 88% of pregnant women had received a pertussis vaccine either during pregnancy or in the preceding 5 years. And for flu, we were up to 81% in July, and that's just astounding, really, for us to be achieving such high levels of protection. And we do, for pregnant women, we do believe that the pertussis immunisation uptake is really probably driving the influenza immunisation uptake, because people don't seem to be quite concerned about influenza compared to pertussis. And I think, you know, it's really important to consider these structures and strategies for improving uptake of vaccines for pregnant women, because we do have new vaccines on the way that are in phase 2 and phase 3 clinical trials. So we do a lot of clinical trials in Australia. It's really interesting to hear about the oral vaccines. And so there are 2 other potential vaccines hopefully available soon. One to prevent Group B streptococcal infection, which is a severe neonatal infection. Rare but devastating consequences and often long-term sequelae, and the leading cause of severe invasive infection in infants under 3 months. And then maternal respiratory syncytial virus vaccine. Really, in our hospital, because we've now really got rid of rotavirus infection, because the rotavirus vaccines work so well, the commonest cause of admission is respiratory infection from RSV. So if we can have an RSV vaccine available, really the paediatricians are not going to have much to do. So, although they probably argue that. But, you know, and many of you here will know that there's been so much difficulty around development of RSV vaccine, particularly the live attenuated vaccines for infants, that maternal RSV vaccine offers an opportunity to provide protection against this infection. And that's it, really. So I just think, you know, just to summarise, to say that there is a significant burden of disease in pregnant women and infants, and we have safe and effective vaccines available. Important to continue surveillance once these vaccines are introduced for any safety concerns or problems with efficacy, and particularly those infant responses, as I mentioned, but also to look at the structural processes that need to be in place to really make sure we get good and adequate coverage for pregnant women, particularly as new vaccines are on the way. And that's just my team to acknowledge, do all the work. Thank you.
Thank you very much.
I like the presentation, but I'm a little bit confused.
Sure.
As pertussis vaccine is part of a childhood vaccination program. So how can it be that there are so many mothers who were child at one time and went through the regular vaccination program and were unvaccinated? Or is the unvaccination preferring as adult revaccination? So could you please elaborate on
Yeah,
that?
sure. What was the first part of the question?
Pertussis vaccine is part of the required childhood vaccination. So how come you have so many mothers who were never exposed to pertussis vaccination?
Sure, yeah. So they would have been. So as infants, depending on their age, of course, the pertussis vaccine came in the 80s from memory, with a wholesale pertussis vaccine, and because of the reactogenicity associated with wholesale pertussis vaccine, ascended pertussis vaccines were developed and implemented, and we changed over in the sort of late 1990s to ascended pertussis vaccines, which are effective overall, but not as effective as wholesale pertussis vaccines. So, and as ascended pertussis vaccines are less reactogenic, they're more accepted by the community, but unfortunately they just don't provide long-term protection. They probably provide protection, you know, maybe for five years. So that's why we have the infant and the booster program. So mothers would have had some pertussis vaccination during pregnancy, but it wanes. And so though some of them have antibody levels or low antibody levels, they're really not sufficient to provide protection for the newborn over that first few months of life. Does that answer your question?
Well, it does, because that means that even though they got the vaccination as childs, you measure the antibody responses in the exposed pre-vaccinated mothers and you boost the immune response.
That's right.
So it's not really unvaccinated people.
No, that's a very good point, actually.